while immune checkpoint blockade therapy represents an enormous advance in the treatment of advanced bladder cancer, unfortunately, it still is the fact that only a minority of patients respond to the treatment. Approximately 30% of patients will respond to pembrolizumab in the first-line setting, about 24% to atezolizumab in the first-line setting in cisplatin-ineligible patients. And in the second-line setting, the response rates are approximately 15 to 21%. Clearly, we need to do better. 75 to 80% of patients are not deriving substantial benefit from these treatments. But the people who do derive benefit derive dramatic long-term benefit often with durable responses. And many of the trials that are ongoing have not yet reached the median duration of responses for these patients, suggesting that these are on the order of 2 to 3 years, if not longer. And certainly in my own practice, I have patients who were on the original clinical trials with these agents and are still responding to therapy 3 and 4 years later. So it's very exciting for the people where it works, but we're left with a very large group of patients where the immune drugs are not providing dramatic benefit. So there are certain strategies that we can think about to try to combine agents that might improve the likelihood of response and clinical benefit with immunotherapy in bladder cancer. One obvious one is with chemotherapy, and that's multiple trials are testing standard chemotherapies in combination with immunotherapy. There are phase 2 pilot studies asking particular questions and larger randomized phase 3 trials going on that are trying to answer definitively whether or not it improves survival in patients who receive immune checkpoint blockade, and hopefully we'll know the answer of this in the next several years. There are also many efforts looking at other approaches to combine novel targeted agents, focusing either on immunotherapy or other approaches to lead to improved outcomes. There are agents targeting angiogenesis, such as bevacizumab, targeted therapies, TKIs, also are still going to be tested in bladder cancer in combination with immunotherapy. There are immune-immune combinations of multiple types, including drugs focusing on the indoleamine deoxygenase activity pathway, IDO1 inhibitors. And several of them have actually showed proof of concept activity in combination with immune checkpoint blockade in bladder cancer, showing response rates that were substantially higher than what you might expect with the single drug by itself, fortunately without tremendous toxicity. Another very interesting area are DNA vaccines, where patients have where DNA is injected into the patient along with an immune stimulatory molecules to lead to a new immune response against cancer-related antigens. Biomarkers to select patients for treatment of bladder cancer remains a very controversial area. PD-L1 testing on tumor cells or immune cells by immunohistochemistry has not proven useful at this point in bladder cancer the way it's been proven more useful in lung cancer and other diseases. In 2 randomized phase 3 trials, PD-L1 testing failed to really demonstrate a useful effect. In the pembrolizumab randomized phase 3 trial, which supported the drug approval in the second-line setting, PD-L1 testing did in fact show that the drug worked better in PD-L1 positive than PD-L1 negative patients. But in fact, when you look at the trial, the PD-L1 negative patients who got pembrolizumab did the best. So it's really not a helpful biomarker to pick patients. You're going to pick people, if you use that biomarker, you're not going to pick the patients properly. In the atezolizumab phase 3 trial, which was a negative phase 3 trial, the high levels of PD-L1 expression predicted response to both chemotherapy and immunotherapy. It used a different test, the SP142, than the pembrolizumab trial. But that trial also showed that, in fact, it's not a useful biomarker and that it highlights probably a better prognosis group of patients or is predictive for both chemotherapy and immunotherapy response. And so PD-L1 testing at the moment is not useful in bladder cancer, and I don't recommend it or use it in my practice. It may highlight groups of patients that might be useful in the future with other targeted combinations in particular subpopulations, but right now it's not really a useful test. Tumor mutation burden, on the other hand, is a very interesting concept that has been shown in many disease types to be associated with improved outcomes and also shown in bladder cancer. In our study of atezolizumab, the phase 2 study that led to FDA approval, we showed that the total number of mutations was highest in the responders, and in fact the top quartile of patients had improved overall survival, so not only led to improved tumor shrinkage but also improved long-term outcomes. Other studies have shown this, and another interesting potential biomarker of response to immune checkpoint blockade is actually the presence of DNA damage repair mutations, not beyond things that we know about, like MLH1, MSH2, the mismatch repair pathway. The presence of DNA damage repair mutations in bladder cancer in tumors appears to be associated with substantially higher response rates as well. And it's probably in part mediated through tumor mutation burden, but provides a very discrete way of measuring whether or not a patient's tumor is likely to respond to immunotherapy. Because tumor mutation burden is a continuous variable, and it's not clear if someone has 7 mutations is going to do worse than someone who has 9 mutations if your threshold is at 8. And whereas the presence of a DNA damage repair mutation might actually demonstrate the fact that the tumor is poised to respond because there are more neoantigens available.